Let's jump right into this explainer and master acute respiratory distress syndrome, or ARDS. If you've ever felt completely overwhelmed by ventilator settings, oxygenation ratios, and all those ICU protocols, you are in exactly the right place. Today, we're going to break down ARDS using simple, unforgettable comparisons to help you absolutely lock down these key facts for your board exams and your ICU rotations.
Here's our game plan for today. We'll start with the Berlin definition checklist, move into the leaky sponge pathophysiology, talk about gentle breaths ventilation, hit rescue therapies, and finish up with crucial ICU traps.
All right, Section 1, the Berlin definition checklist. We're framing the problem here. In the ICU, we don't just guess, right? We use a very strict 4-part checklist to define exactly what ARDS is.
So a patient absolutely must tick every single one of these 4 boxes to get that formal ARDS diagnosis. First up, timing. The respiratory decline has to happen within 1 week of a known clinical insult. Second, imaging. You need to see bilateral infiltrates. Basically, both lungs look fluffy and white on a chest X-ray or CT. Third, origin. You've got to rule out hydrostatic edema. In plain English, this fluid cannot just be cardiogenic pulmonary edema from a failing heart. And finally, oxygenation. They need a severely impaired P to F ratio. That's the ratio of arterial oxygen to the fraction of inspired oxygen, all while on at least 5 centimeters of water of PEEP.
And once that checklist is met, the severity scale kicks in. Mild, moderate, and severe classifications are strictly defined by exact P to F ratio cutoffs. It's pretty straightforward. Between 200 and 300 is mild, drop below 200, you're looking at moderate. And if that ratio completely crashes to 100 or below, you are dealing with severe ARDS. Definitely memorize these 3 tiers because your entire treatment strategy hinges on exactly where your patient lands here.
Okay, moving to Section 2, the leaky sponge. Let's look at the pathophysiology and causes and figure out what is physically going wrong inside that injured lung to make oxygen transfer so incredibly hard.
First, what's the trigger? The initial insult is either a direct pulmonary hit, think pneumonia, aspiration, or even drowning, or it's an indirect systemic hit. Actually, fun fact, sepsis is the most common overall culprit for ARDS. The massive systemic inflammation from sepsis travels through the blood and basically attacks the lungs as an innocent bystander. So the real key is understanding that attack mechanism. I want you to think of the affected alveoli not as nice stretchy balloons, but as a leaky sponge. This huge inflammatory response drastically increases the permeability of the alveolar capillary barrier. Your alveoli just fill up with this sticky, protein-rich, non-cardiogenic fluid. It's a disaster for breathing. It completely wipes out your surface area for gas exchange, inactivates surfactant, and drastically tanks lung compliance. You're literally left trying to ventilate a heavy, wet, leaky sponge.
And that leaky sponge goes through 3 distinct chronological phases. First, the immediate exudative phase happens in the first week. That's when the high-protein edema floods in and forms thick hyaline membranes. Then, moving into weeks 2 and 3, we hit the proliferative phase. This is where the body sends in macrophages to try and clean up the mess. Finally, in some really unlucky patients, they reach the fibrotic phase. That's where the inflammation turns into irreversible alveolar interstitial fibrosis, permanently stiffening the lung.
Let's jump to Section 3, gentle breaths, ventilation strategies. You simply cannot ventilate an ARDS lung the way you'd ventilate a healthy one because the lung's physical state completely dictates our mechanical protocol. Before we even think about touching the ventilator dials, we need to visualize the physical forces at play inside a patient lying flat on their back in the ICU. Like, how does gravity interact with our wet, heavy, leaky sponge? Picture a 3-layer cake. Because the lung is so wet and heavy, gravity creates 3 very distinct zones. The top layer of the cake, the non-dependent zone, is airy and totally open for gas exchange. The bottom layer is squished flat by the sheer weight of the fluid above it. We call that compressive atelectasis. But honestly, the real danger is the middle layer. It's caught right between the open top and the squished bottom, so it keeps dangerously snapping open and abruptly shutting with every single mechanical breath. That's cyclic atelectasis, and it literally rips the lung tissue apart over time. Because of that fragile middle layer constantly snapping open and closed, the absolute golden rule of ARDS is that all patients require a lung protective strategy. If you blast this lung with normal, large volumes of air, you will cause ventilator-associated lung injury. You're basically popping the few remaining healthy alveoli like an overinflated balloon. We definitely do not want that. To protect that fragile balloon, you've got to remember this magic number.
Target small, gentle breaths of just 4 to 6 milliliters per kilogram of ideal body weight. And note that I said ideal body weight, not actual body weight. Lungs don't grow when a patient gains fat mass, right? So keep those volumes tiny.
Along with those gentle volumes, you have to keep a super close eye on the airway pressures. You need to keep the plateau pressure strictly under 30 centimeters of water. But even more crucially, keep your driving pressure, which is just your plateau pressure minus your PEEP, under 15 to 17. High driving pressure is actually one of the strongest predictors of mortality in ARDS. Now, because we're taking such small breaths, carbon dioxide is going to build up in the blood. And you know what? We accept this. It's called permissive hypercapnia. As long as the pH stays above 7.30, we tolerate the extra CO2 to protect the lung.
All right, Section 4, rescue therapies and ECMO. So, what happens when the gentle balloon strategy fails? We need to know the escalation protocol for when our ventilation strategy just isn't cutting it for severe, life-threatening hypoxemia. Remember our 3-layer lung cake? To fix that squished bottom layer, prone positioning, which is literally flipping the patient onto their stomach, is strongly recommended for at least 18 hours a day when the P to F ratio drops below 150. It relieves that compressive weight and drastically improves ventilation perfusion matching. It is a total game changer. On the flip side, high-frequency oscillatory ventilation, or HFO, is strongly recommended against. It might sound super high-tech, but the data actually shows it can damage the right ventricle and harm our patients, so skip it.
Other rescue options? Well, you can temporarily paralyze the patient with neuromuscular blockers in the first 48 hours. This stops them from fighting the ventilator and significantly drops their oxygen consumption. You might also run into advanced ventilator modes like APRV, which holds a high continuous pressure to pop alveoli open, then briefly releases to dump CO2. Or you could try inhaled vasodilators like nitric oxide. But a quick heads up on those, they give a nice transient boost to oxygenation, but studies show absolutely no overall mortality benefit. Now, if all else fails and the patient is literally suffocating, despite perfect ventilation, paralysis, and proning, we look to the EOLIA criteria. If they hit extreme benchmarks, like a shockingly low P to F ratio under 50 for over 3 hours or under 80 for over 6 hours, they need an immediate referral to an ECMO center. ECMO is the ultimate rescue. It bypasses the lungs entirely, oxygenating the blood outside the body so those highly inflamed lungs can just stop and rest.
Finally, Section 5, crucial ICU management traps. Let's wrap this explainer up by looking beyond the ventilator dials. There are 3 major clinical traps that can easily jeopardize your patient's recovery if you aren't paying close attention. These traps catch a lot of new clinicians out, so listen up. Trap number 1, using non-invasive ventilation, like a standard BiPAP mask, on moderate to severe ARDS patients. Studies like Fleur-Lee show this actually increases mortality. Why? Because you can't control the tidal volumes, so the patient ends up taking huge, lung-damaging gasps. Trap 2 is all about timing your steroids. Giving them early might help, but giving steroids past day 14 of ARDS has actually been shown to increase mortality. And trap 3, that brings us right back to our most important analogy, fluid overload.
Let's think back to our leaky sponge. An ARDS lung is incredibly vulnerable to worsening edema. To get your patient better, you absolutely must maintain a conservative negative fluid balance. We use diuretics, we restrict fluids. We literally want to dry out those lungs to decrease that heavy fluid burden. Drying the sponge is what gets the patient extubated and off the mechanical ventilator so much faster.
And I'm going to leave you with this provocative thought to ponder before your next ICU rotation. We know sepsis is the #1 cause of ARDS, right? And sepsis protocols demand we blast the patient with aggressive, early IV fluids to save their blood pressure. But how on earth do we balance those initial life-saving floods of fluid against the absolute necessity of keeping the resulting ARDS lung bone dry? It is literally one of the greatest tightrope blocks in intensive care medicine. Thanks so much for joining me. Keep these analogies in your back pocket, and I'll see you on the wards.